All right, let's talk about GI infections. They're a core part of what you see day in and day out as a medical trainee. So today we're doing a high-yield, high-speed review. This is designed to get you the key clinical info you need for your rounds, for your exams, and of course, for your patients. Okay, picture this. A patient walks into the ED with acute diarrhea. This is probably one of the most common things you'll ever see, right? And the list of what could be causing it can feel, well, just overwhelming. The key is to stop trying to memorize a giant list and start thinking with a structured, syndromic approach. So let's build a framework that's not just going to sharpen your clinical reasoning, but is absolutely essential for board prep. First up, let's tackle the most common presentation, watery diarrhea. The big thing to remember here is that it's typically non-inflammatory. So instead of physically invading the gut lining, these pathogens are sneaky. They release enterotoxins that basically hijack the intestinal cells and tell them to just pump out water and electrolytes. And that's what leads to that classic high-volume watery stool. Now, let's meet the big three for watery diarrhea. For your exams, you have to know these buzzwords. When you hear Vibrio cholera, you should immediately think rice water stool. It's all thanks to a toxin that cranks up intracellular CAMP, which just opens the floodgates for water to pour into the gut. Traveling somewhere? The number one suspect for traveler's diarrhea is E-tech, or enterotoxigenic E. coli. And for those sudden outbreaks, on a cruise ship or in a daycare, norovirus is almost always the bad guy. Okay, now the entire clinical picture changes the second you see blood. This isn't just about losing fluid anymore. Blood is a literal red flag. It tells you that a pathogen is actively invading the gut's mucosal lining, causing real, direct tissue damage and a whole lot of inflammation. And this slide really highlights that fundamental split in how we think about this. On one hand, you have watery diarrhea. That's a toxin-mediated thing happening in the small intestine, and our main worry is dehydration. But on the other hand, you have bloody diarrhea, or dysentery. Now we're talking about direct mucosal invasion down in the colon. And that's what brings systemic symptoms like fever and abdominal pain right to the forefront. So let's run through the key players for invasive bloody diarrhea. You absolutely have to nail these associations. Campylobacter jejuni is the most common bacterial cause here in the US, and you've got to remember its link to Guillain-Barré syndrome. Then you have Shigella and EHEC. Enterohemorrhagic E. coli, which both produce a Shiga toxin that can lead to hemolytic uremic syndrome, or HUS. And don't forget the parasites. Entamoeba histolytica causes amoebic colitis with those classic flask-shaped ulcers you hear about. So this is a huge clinical pearl, a major safety issue. If you suspect an EHEC infection, you generally want to avoid antibiotics. Why? Well, there's evidence that killing the bacteria can cause them to release a massive amount of their Shiga-like toxin all at once. And that can actually increase the patient's risk of developing that devastating complication, hemolytic uremic syndrome. So for these patients, supportive care is really the mainstay of treatment. All right, let's shift gears. We've been talking about acute infections, but now let's talk about a bug that plays the long game. Helicobacter pylori is a master of chronic infection. It basically sets up a permanent camp in the stomach and can lead to gastritis, ulcers, and even stomach cancer down the line. So, when should you be actively testing for H. pylori? Well, definitely in any patient who has active peptic ulcer disease, or even a history of it. You also test for it in a specific type of stomach lymphoma called gastric malt lymphoma. Testing is also key for patients with unexplained dyspepsia or before you start them on long-term NSAID therapy, non-steroidal anti-inflammatory drugs. Getting rid of this bug makes a huge difference in reducing the risk of both ulcer recurrence and gastric cancer. When it comes to treatment, this is your go-to. The classic first-line choice is bismuth quadruple therapy. It sounds like a lot, but it's a combination of a proton pump inhibitor, bismuth, and 2 antibiotics, metronidazole and tetracycline. The key is they have to take it for a full 14 days. It's a really effective combo for knocking out the infection. Okay, finally, let's talk about an infection that is a true modern-day hospital menace. This is one that every single trainee has to master, Clostridioides difficile, or as we all call it, C. diff. It's the #1 cause of infectious diarrhea that people get in the hospital. The story of a C. diff infection is a classic one. You've probably seen it a dozen times. It almost always starts with a course of antibiotics for something else, which just wipes out the patient's healthy gut bacteria. This creates the perfect opening for any ingested C. diff spores to germinate, start growing, and produce their toxins, which leads to that severe mucosal damage and colitis. Now, diagnosing C. diff can be a little tricky because of the tests we have. The NAAT or PCR test is super sensitive, so a negative result is fantastic for ruling out an infection. But its weakness, it can't tell you if it's an active infection or just harmless colonization. That's where the toxin EIA comes in. It's not as sensitive, but it's highly specific. It confirms active toxin is being produced. And that's why a lot of hospitals now use a two-step algorithm to get the best of both worlds. And here's how we manage it. For first-time episode, oral vancomycin or the newer drug fidaxomicin are your first-line choices. But the real challenge with C. diff is when it comes back. For a first recurrence, you might try a long-tapered or pulse dose of vancomycin. But by the time you're seeing a second or third recurrence, you're starting to think about advanced therapies like fecal microbiota transplantation, FMT, to try and restore that healthy gut microbiome.
So, we have covered a ton of ground, right? From watery to bloody diarrhea, from acute bugs to chronic culprits. So how do we pull all this together into a framework you can actually use on your next shift? Well, here's your diagnostic playbook. Think of this as your cheat sheet for acute diarrhea. First thing you do, differentiate. Is it watery or is it bloody? That's your most important fork in the road. Second, your history is everything. Ask about travel, food, and recent antibiotics. Third, use that history to order targeted stool studies. Don't just shotgun the lab with every test. And finally, always remember those high-risk associations. HUS with EHC and Guillain-Barré with Campylobacter.
Look, if you only take one single thing away from this explainer, let it be this. Starting with that simple clinical question, is it watery or is it bloody? That is what organizes your entire thought process. It narrows down your differential, it focuses your history taking, and it guides your entire workup from the moment the patient walks in. And that leaves us with a really interesting question for the future. We're already seeing the power of microbiome restoration with FMT for recurrent C. diff. So is this going to become the primary way we manage a much wider range of GI infections? It's a field that's evolving so fast, which makes understanding these foundational concepts more critical now than ever before.